Hello and welcome to the program. I'm your host, Neil Howard, here on Health Professional Radio. Glad that you could join us. Going to have a conversation with Dr. Yutaka Niihara. He's here to talk about sickle cell disease in the underserved minority population and his passion for finding a treatment. Now, for the first time in 20 years, there is a treatment, and it's been recently approved by the FDA. Welcome to the program, Dr. Yutaka.
Thank you, Neil. It's really a pleasure for me to speak with you and your audience, and I really appreciate this opportunity.
Have you always been a sickle cell researcher? Is that your passion from the beginning of your medical career?
When I first entered medical school, I barely graduated from medical school, but I did find the interest in cancer. So I started to study cancer in my postgraduate training. But when you study cancer, you also have to study blood diseases. That's when I met some of my first sickle cell patients. Mm-hmm. And that's when my passion for sickle cell disease, I guess, started realizing how horrendous the disease is and how devastating the patients' situations are.
For those of us who may not be familiar with sickle cell, explain briefly what sickle cell disease is, who's at risk, and what are the complications involved.
So sickle cell disease is a genetic disease, affects mostly people of African descent, also affect people of Middle Eastern descent and Hispanic descent, and also Indian people. And this mutation was preserved over the years, even though it can cause devastating disease, because if you have just one of the two genes, patients actually do well by resisting malaria, especially in the area where malaria is quite prevalent. But if someone has two genes, which is possible if a person who carry one gene and the other person who carry one gene get together and have a child that have two genes, then the disease can be quite devastating. And what it does is this mutation causes hardening of the red blood cells. Red blood cells carry oxygen to different parts of our body. But because this red cell becomes hardened and get injured, it becomes kind of sticky, and it starts to block small blood vessels of our body. So you can imagine the complication of blocking blood vessels. It's like having mini strokes or heart attacks throughout their body. In fact, most of the patients who die of organ failure with the injuries after injuries occurring in their organs, heart, lungs, liver, kidney, and brain. And sometimes they can have these very acute, devastating events can occur, like a major stroke, major heart attack, and many of the patients do have kidney failure, has to be on dialysis. Overall, in developing countries, sickle cell patients, majority may survive till age 5. Infection is another major cause of death because this blockage of blood vessels leads to failure of our immune organs, and they become very susceptible to infection. And because we have a little better supportive medical care, so they can survive longer, but to die 40s. Most of my patients did not survive beyond 40s. So to make a long story short, the complications, it essentially involves every organ in the human body. But it's not just a complication of these organ failures and infections, but they have episodes of, and the pain is severe. Many of my patients describe this as one of the worst. And younger patients of mine describe this as somebody hitting my shin with a bat as hard as they, and this just stays there constantly. That's how terrible this disease is. Yeah.
How many people in the United States are dealing with sickle cell? And is this something that is, you say, African descent, Middle Eastern descent? How many would you say are dealing with sickle cell on a worldwide basis?
Okay. So in terms of sickle cell disease, in this country, we have about 100,000 patients. And in Europe, probably we have another 80 to 100,000. Middle East, probably another 400,000 patients. And worldwide, especially in Africa, include that we probably have about 25 million sickle cell patients. So, this does affect a large number of patients worldwide.
So what are the options out there traditionally? And let's talk about this new option, Endari.
Yes. So until recently, we had no options really except to, give pain medicine, give hydration. We call this supportive care. 1998, we had hydroxyurea. This is a chemotherapy, and it was rather a drastic measure, but it was at least preventing painful crisis. This is this really intractable pain that requires a lot of morphine every time they have a obstruction of blood vessels. Now, for very, very limited number of patients, bone marrow transplantation is available, but you have to have a donor, which usually has to be among siblings. And this can actually cure the disease, but this is just so rarely available that only very, very few patients can receive it. So after hydroxyurea, we really didn't have anything for adult patients, and we never had anything for pediatric patients. I have been working on this since 1992 based on the knowledge that my mentors gave, and they have been working since 1970s. What we wanted to do was we cannot fix this disease completely, but we can prevent the hardening and stickiness of these red blood cells. And in order to do this, we should try to minimize the injury to the red blood cells, which is caused by this mutation. So when there's injury, there is something called oxidation. It's kind of like sunburn or inflammation. And this inflammation is, our way to prevent the infection to come into the body. But inflammation can be so much that it actually destroys or damages the cell too much. And then this leads to the hardening and stickiness of red blood cells. We found that there is a way to reduce this injuries and hardening by reducing the oxidation process. And we found a way to reduce oxidation process, and I'm not going to go into details of what we have done to discover this, but we were able to reduce this hyper-oxidation process by using L-glutamine, which is really what Endari is. And once we reduce this injury, there is an injury and inflammation. The further injury was prevented because what happens, like injury induces inflammation. Inflammation further injures and hardening, and that further inflamed. So it's kind of like a vicious cycle and vicious spiral. So we stopped this vicious spiral at the inflammation level. So we have not cured, but it's almost like, diabetes patients. We haven't cured diabetes, but we are able to reduce the complication of diabetes. Like blood pressure patients, we cannot cure hypertension, but then we can lower the blood pressure and prevent the complication of people with high blood pressure. And that's what we have done. And we have been able to reduce the oxidation of this red cell. And as a result, the stickiness of the red blood cells have gone down. At the clinical level, we have shown that this can reduce the number of this painful episode, which is due to blockage of the blood vessels, and we are able to reduce the hospitalization of these patients. And one of the most severe complications as a result of these is called acute chest syndrome, where patients will actually shut down their lungs. And we are able to prevent this acute chest syndrome in 63% of patients using this medication in 1 year's time.
Well, where can our listeners go and get some more information about this exciting, recently FDA approved, 2017 it was approved, is that correct?
Yes. And
where can you go and learn more?
Well, you can go to your hematologist, or you can, go onto our website, or you can also come to Russo Partners, who has all the information about us. And right now, this is covered by almost every insurance that's available. And sometimes copay is an issue, but now we have a copay program so that even if they have higher copay, we can assist you so that we can reduce the copay down to probably down to $20 a month or so.
Doctor, it's been a pleasure. Thank you so much for this very exciting, very promising information about sickle cell treatment for the first time in 20 years. There's Endari. Thank you so much, Dr. Yutaka Niihara.
Thank you, Neil. I really appreciate this opportunity.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Transcripts and audio of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to this podcast on iTunes, listen in, and download at SoundCloud. And be sure and visit our affiliates page at hpr.fm and healthprofessionalradio.com.au.
Thank you for listening to Health Professional Radio. We're very proud to be an independent broadcaster providing our content free of charge to you, the listener. One of the ways that we're able to remain free and independent is by having people like you become patrons. You can support Health Professional Radio simply by visiting hpr.fm and clicking the button that says Become a Patron. Your patronage of even just $1 a month lets us know that you're there, which in turn makes us more valuable to advertisers. And, of course, if you're able to afford more, then we would certainly appreciate the support. My name is Toby Longhurst from Health Professional Radio. Please visit hpr.fm, click the Become a Patron button, and support us if you can.